Good afternoon, everyone. So we'll start the first one. So I think each talk is 5 minutes, and I think we'll try and stick to time. And for the first talk, I'd like to invite Dr. Shivani Chaturvedi, who will be speaking on OCT angiography metrics correlate with glycated hemoglobin in diabetic retinopathy.
Good morning, everyone. I'll be speaking on optical coherence tomography, angiography metrics, correlation with glycated hemoglobin levels and diabetic retinopathy. As we all know, glycosylated hemoglobin level forms with the binding of hemoglobin and blood sugar. It reflects the average glucose levels over the past 3 months and remains unaffected by the short-term fluctuation of blood glucose levels. It's a gold standard for glycemic control, and we all know with the rise of glycated hemoglobin levels, the risk of diabetic retinopathy increases. Optical coherence tomography, angiography, is a non-invasive method, and it visualizes the superficial and deep retinal plexus without dyes. It reveals the microvascular and deeper layers for better disease understanding. So the aim of our study was to sort the association between the OCTA matrices and the systemic HbA1c levels in diabetic retinopathy, and also to correlate the stages of diabetic retinopathy with the optical coherence tomography parameters reflecting the neurovascular unit. It was a tertiary care center-based cross-sectional study. A total sample size was 112, and it was divided into 4 groups: controls, no diabetic retinopathy, proliferative, non-proliferative diabetic retinopathy, and proliferative diabetic retinopathy, with each group having a sample size of 28. The systemic HbA1c levels were measured with the chromatographic methods, and the STOCT parameters measured were foveal avascular zone, superficial vessel density, and deep vessel density. So we all can see in this box and whisker plot that is with the rising systemic HbA1c levels, the stages of it rises with the severity of the disease. Here also we can see that the foveal avascular zone is rising with the severity of the disease, whereas the vessel density is decreasing as the severity of the disease increases. On bivariate analysis, we see that the R values, there is a positive correlation with the foveal avascular zone with the rising disease severity, and there's a negative correlation with the vessel density. So in all, I would like to conclude that HbA1c shows significant association with optical coherence tomography, angiography matrices in diabetic retinopathy. That is, foveal avascular zone increases with the disease severity, and the vascularity, that is superficial and deep vessel density, they decreases with the severity. OCTA detects subtle microvascular changes, and it facilitates the targeted screening and monitoring of diabetic retinopathy progression. Thank you.
Do you have a data to support these findings? The number of cases which you have done and all that?
Sorry, sir. What?
Do you have a data to support all these
Yes,
findings?
sir, I have. But because of the paucity of the time, I have not mentioned it here. But I have collected the data in the tabular form.
No, but I think you just finished in 2 minutes. You should have covered all that. How many cases have you done?
So 112 sample size was taken, and there were 28 controls, 28 people in no diabetic retinopathy group, 28 in non-proliferative diabetic retinopathy, and 28 in proliferative diabetic retinopathy.
And what the biomarkers you were looking for?
Sir, basically we wanted to see, because the subtle microvascular changes are not discerned clinically. So we wanted to correlate these OCTA parameters with HbA1c levels, and we can, so that we can diagnose it earlier for better understanding, monitoring, and management of the disease.
So what OCTA biomarkers were you looking at?
Sir, foveal avascular zone, superficial vessel density, and deep vessel density.
But so my question is that you've anyways not taken pre-diabetics or let's say, like you say, a normal control if you take, or you take a disease
no
factor.
diabetic retinopathy patients.
No, but what is the confusion in diagnosing an FAZ increase in a PDR case?
So there is no confusion, but...
so then why OCTA? I mean, if you, like we have pre-perimetric changes. So if you talk about that higher HbA1c levels have certain changes on octa which can be discerned before clinical signs come. I don't think that if you have a group, so that is what I agree to what sir is saying. Basically, you have not shown your groups. So when you don't show your groups, so if you're saying that you're taken PDR cases, so what's the confusion in diagnosing an FAZ increase in a PDR or a decrease in, what is the cause for decrease in vision in PDR?
So the changes occurring in the neurovascular unit of the retina, the damage.
No, what are the two causes for decrease of vision in PDR? Simple. It's a very simple question, basic question. You don't need octa for that.
Some macular changes, diabetic macular edema is the main cause, and the other factor is because of the exudation and the hemorrhages.
So
which
that's
are
all. So basically, the main cause for decrease in vision in PDR would be vitreous hemorrhage and macular changes. That's all. So there is no confusion in diagnosing that. So why do we need octa for that? So I think if you want to really go ahead with this, I think as sir said, I think you need data. And one is that either you compare early NPDR or mild to moderate NPDR and see whether these new octa changes are having any significant role with HbA1c. I think this has been proven beyond doubt that blood sugar levels are correlated to the disease per se, right?
Thank you so much.
Have you followed these patients up, like when the HbA1c comes down? Are these biomarkers disappearing or something?
No, so we have not done that, but yeah, that's a very good idea.
Yeah, probably you can extend your study and come back with the results. That will be better. Thanks.
Thank you so much, sir.
Next.
So the next speaker is Anusha Chawla. Is she here? She will. She will speak on serious detachment of macula associated with chicken pox, a novel finding.
Good morning, everybody. The topic of my today's presentation is serious detachment of macula associated with chickenpox, a novel finding. So chickenpox is a common viral illness caused by varicella zoster virus, which is usually self-limiting. And the well-recognized cutaneous and systemic manifestations have been reported. Ocular involvement in chickenpox is very rare, which is typically limited to the anterior segment, most commonly causing acute anterior uveitis, may also lead to keratitis, episcleritis, ophthalmoplegia, rarely involving the posterior segment. If at all involving the posterior segment, it generally causes acute retinal necrosis involving the periphery of the retina. In our case, we have discussed an isolated macular serous retinal detachment in association with chickenpox, which has not been previously documented in literature. So beginning with the case presentation, ours was a 20-year-old male who presented to us with chief complaints of diminution of vision in left eye. 10 days after having fever with rashes, the diminution of vision was insidious in onset, progressive in nature, associated with pain. The progression of rashes was as expected for a rash of a chickenpox. The medications were as shown below. The general examination was that the patient was febrile and has scabs which were crustings present diffusely over the trunk and the proximal limbs. The ophthalmological examination for the right eye was within normal limits. For the left eye, the patient has a severe diminution of vision with a vision of finger count close to face. The anterior segment was unremarkable, and the fundus segment has the findings as shown in the figure, where we can see retinal folds which demonstrate serous macular detachment. An SD-OCT was done, and that confirmed the finding of macular detachment with a central subfield thickness of 355 micrometer. A fundus fluorescein angiography was done, which showed a hot hyperfluorescent disc. Investigations were done. Varicella zoster virus DNA PCR and ELISA was done, which came out to be positive. And the treatment that we gave to the patient was we kept him under observation and continued his oral medications and monitored him on a 1 monthly follow-up, where we observed that the detachment was progressively regressing. At a 3-month follow-up, when the patient came to us at a 3-month follow-up, the vision was restored to 6/6, and there was complete resolution of serous macular detachment on the fundus, as well as the central subfield thickness on the OCT was 232 micrometer. So the possible mechanism of the transient isolated macular serous detachment that we see can be explained by the varicella zoster virus replication at various levels. When the virus replicates inside the infected T lymphocytes, the T lymphocytes can lead to inflammation leading to exudation. It can cause replication in the capillary endothelial cells, when the virus exits the vascular system, it can lead to vasculitis. The replication in the RPE can lead to the compromised integrity of the RP, leading to the compromised integrity of the outer blood-retinal barrier, leading to, again, exudation and the serous macular detachment. So the take-home message for us is that although rare, ocular findings have been reported in cases of chickenpox, and this highlights the need for careful retinal examination and fundus evaluation in systemic viral exanthems like chickenpox. Thank you.
Good. So this was just a single case.
Yes, sir.
So what is your working diagnosis? Are we dealing with some kind of optic neuritis or something?
Sir, optic neuritis has been previously reported. We are dealing with the involvement of the serous macular detachment.
No, but you said the disc also hyperfluorescent.
Yes, sir. So, but that is not a novel finding that we are focusing on in our presentation. The novel finding is that the macular, there was a transient serous macular detachment. That has not been reported before.
No, but even with optic neuritis, the fluid
Yes,
can
sir.
trickle down up to the
Yes,
fovea.
sir. Yes, sir.
So what was the cause for the NST?
Sorry, sir.
What was the cause for the serous detachment to happen?
So the mechanisms that we have that have been proposed are the replication of the varicella zoster virus at various levels. When it replicates at the level of T lymphocytes, it can lead to inflammation and exudation. When it replicates at the level
So
of
wouldn't you call it RP epithelitis? RP epithelitis has been reported. So is it not, could it not be RP epithelitis? Secondly, you're talking about vasculitis,
Yes,
but
sir.
you've not shown any peripheral scans and of vasculitis. And why would vasculitis again come with, because RP epithelitis is known to cause NST, present
sir.
with an NST.
Yes, sir.
But vasculitis per se would not primarily cause, this thing. But I'm not very sure, because if there's vasculitis, because you
Yes,
said that the
these are
disc is hot, but it is not leaking.
Yes, sir. It is not leaking.
So hot disc is usually called when it is leaking.
Yes, sir. But the disc is hyperfluorescent. It is not leaking, but it is hyperfluorescent.
Yeah, so the mechanism, I think, is a little this thing. I mean, I agree to what sir is also saying. It's definitely inflammatory.
Yes,
But
sir. It is
then,
definitely inflammatory.
I think you should go deeper into details as to what is the cause for the NST to come in.
Yes, sir.
On fundus fluorescein angiography, you see some pattern for serous detachment? On fundus fluorescein angiography, there was ink blot pattern or something else like that?
No, sir. No, ma'am. No, ma'am.
So
No
that
leakage.
is what-
Any
so-
visual evoked responses were done?
Sorry,
or-
sir.
Visual evoked responses or multifocal ERG, anything was done?
No, sir.
Thanks a lot.
Thank you.
Thank you.
So the next speaker is the Dr. Charu Arora. Is she here? Charu? The next speaker is Khyati Yadav. No? Rohit Banot. He will speak on association of serum vitamin D levels with the spectrum of CSR patients of Indian origins. Over to you.
Good morning, sir. Good morning, everyone. My paper presentation will be on the association of serum vitamin D levels in clinical spectrum CSCR in patient of Indian origin. As we know, it's a retinal disorder characterized by localized serous detachment of the macula with or without focal pigment epithelial detachment. It generally affects young to middle-aged man between 30 to 50 years of age. CSR can be categorized into acute, recurrent, and chronic. Though the exact pathophysiology of CSR is still not clear, but it is known to be mainly related to type A personality, anxiety, and stress level. If it goes the main etiology, choroidal vascular hypermobility is one of the main reasons. Now, coming to the vitamin D, it is essential hormone for growth, development, and skeletal structure that regulate calcium and phosphorus metabolism in the body. Now, coming to the purpose, what was the purpose of our study? It was to investigate the level of serum vitamin D in different clinical profiles of CSR in patients of Indian origin. As I have gone through the literature, there was no previous study in literature on vitamin D effects on various clinical profiles of CSR patients, especially in Indian subcontinent, where incidence of CSR is relatively higher than other parts of the world. The effect of vitamin D have been studied in many other ophthalmic diseases like ocular inflammation, angiogenesis, glaucoma, and diabetic eye disease. Now coming to the material and method, this was our case control observation study. All patients were diagnosed on the basis of clinical angiography and optical coherence tomography. It included patients of acute, recurrent, and chronic in variety. Acute, as we know, it localized neurosensory detachment and symptomatic for less than 3 months. Recurrent, new acute CSR episode following a previous completely resolved episode, and chronic, present for 6 months or longer after onset of symptoms. Now, what we have excluded from our study, the patient who have celiac disease, CLDs, advanced stages of CKD, vitamin D replacement therapy, and autoimmune disease. All patients in study and control group were analyzed for fasting blood level of serum vitamin D with the enzyme-linked fluorescence assay with fully automated biometrics VIDAS. Normal level was taken more than 30 nanogram per ml, insufficient between 20 and 30, and deficiency was taken less than 20. The numerical variable between two groups were compared using Mann-Whitney U test, and Z test was used to compare the difference between proportions. At the same time, p-value of less than 0.05 was taken as statistically significant. Now coming to our result, our study included 42 patients of CSR and 44 healthy individuals in control group. 25 patients has acute CSR as a P1, 11 had chronic P2, and 6 presented with recurrent P3 values. Now if we compare the patient and control group for gender, age, and BCVA, it was comparatively same. But if we come to the level of serum vitamin D level, the patient group has significantly lower vitamin D level, and the p-value was significantly valuable. The same has been depicted as per figure legend, as you can see. Now coming to the result of vitamin D level in clinical subtypes. After going through the things, what we have found in acute, we have significantly low level of serum vitamin D. In chronic, same we have found of 72% patients have low serum vitamin D level, and in recurrent we found in 50% of cases. Now coming to the discussion, our study demonstrated that patients of CSR of Indian region have significantly low level of serum vitamin D when compared to healthy control. The significantly low levels of vitamin D were observed in all clinical subtypes of CSR, like in acute, recurrent, as well as chronic setting. There was significantly more number of patients in acute, chronic group with deficient level of vitamin D as compared to normal serum vitamin levels, and none in chronic subtype had normal vitamin D levels. More patients in recurrent subtype also had deficient vitamin D levels, but results were not statistically significant. Though the pathophysiology of CSR still is not fully known, but believe that it results due to abnormal permeability in the inner choroid, which affect the status, ischemia, and inflammation alone or together. It also affects the choroidal hyperpermeability resulting from impaired circulation. If we come to the effect of vitamin D, the deficiency can lead to disrupted retinal microvascular circulation independently of any cardiovascular disease. It also affects the antioxidant mechanism, which has been elicited in many ganglion cell loss associated with vitamin D deficiency. Now coming to what was the limitation of this study, firstly, the vitamin D that we have checked was carried out only in the serum. There was no measurement of vitamin D levels in the aqueous, vitreous, or retinal tissue. Secondly, determination of finding whether or not the patient who recovered with vitamin D therapy is important in respect of understanding the actual effect of vitamin D in pathophysiology of CSCR. In the conclusion, I will say reduction in antioxidant capacity of vitamin D leads to oxidative stress, release of free radicals, and vascular changes that are commonly seen in vitamin D deficiency could have a significant role in pathophysiology of CSCR. Thank you, sir.
So I have, what came into your mind to do this study?
So actually, since I was with my prof and we were more of the cases were coming in at AIOCMTC Pune. So seeing this, then we go through the literature to find any relation with the vitamin D, and since it's much less in Indian original population, vitamin D levels. So then idea has come, why not to check vitamin D levels since it was easily available for us at the microbiology lab, sir. This is how the things have come up. And secondly, if we have gone through the literature, there was only one study that has been done at Turkey by Professor Corbett, who has found vitamin D level only in their subcontinent level. But at the Indian subcontinent level, this type of study has not been done as of now, sir.
No, but vitamin D level to CSR is what I'm asking. How did this come up with your correlation?
So, so if you go through the literature, sir, the the vitamin D, if it's less, it goes through the release of free radicals, sir. If I go through the other literature in the medicine land and other things, it really affects the endothelial levels, sir, that which leads to free radicals and disrupt the microvascular structure, sir, and leads to oxidative stress, sir. That's how it can be correlated to it, but my study still need more elaboration with coming time, how the vitamin D doses and has affect the overall outcome of my study, sir.
No, basically what we are looking for is the cause and effect relationship. So, did you do vitamin D replacement and could you check that the CSR disappeared?
So we have started the therapy, but still result is not with us as of now, sir.
Okay.
It's still into the process, sir. That I will share subsequently.
So, you have not followed up these patients for so long, for that
Not
long?
for so long, sir. Yes, sir.
Okay.
But definitely there was a deficiency in vitamin D level in these cases.
Okay. The other thing I just was coming to my mind was that as we say CSAR is more common in type A personalities and what are the kind of population who were coming to you? Were they more like sedentary office kind of workers who were not having any outdoor activities and things like that?
So it was
So, will that also correlate that type A personalities might have less vitamin D levels?
so in our cases, since more were the of army origin soldiers, which definitely do have a high stress level during duties and other things, the age group was of 30 to 50 years of age, sir.
But
And at the same time, we have a local population.
but I'm surprised that they have low vitamin D levels.
So it can be there, sir. The
higher incidence of
jawans who are
CSR,
posted at high altitude definitely they lack, sir. Many studies have been done this, sir.
So, those are the people who were
Yes, sir.
posted in high altitude?
Do have some. who
No,
have been
and
posted.
out of these, how many?
So we don't have that data much with us, sir, as of now.
Okay.
Though I can say about 5 to 6 on that.
Okay.
Sometimes the platoon who come back from high altitude to the PC area, sir.
Okay.
So this is how we come and collect the data, sir.
Okay. So, the data is still fragmented and
Yes,
we
sir.
don't know the
We want
exact
to
pathophysiology, neither of CSR nor of vitamin D deficiency.
see, yes, sir. We are still working on it, sir.
Okay.
How the vitamin D supplement therapy will affect the results, sir.
Thank you.
Thank you, sir.
So the next speaker is Dr. H.B. Sharan. He will speak on retinal and choroidal microvascular alteration in HIV individuals using OCTA, cross-sectional analysis.
Good morning, everyone. Myself, Dr. Sharan, junior resident from AFMC Pune. I will be presenting a paper on assessment of retinal and choroidal microvascular alterations in HIV positive individuals using optical coherence tomography angiography with CD4 count correlation. Introduction: retinal vasculature offers unique opportunity to study microvascular changes affecting systemic vascular health. Current study investigates subclinical microvascular changes in well-controlled HIV positive individuals using OCTA. There are other studies which shows the clinical changes. Aims and objective: the primary aim of this study is to evaluate retinal and choroidal microvascular changes in well-controlled HIV positive individuals on ART using OCTA. Primary objective is to investigate differences in macular vessel density and macular vessel linear density between well-controlled HIV positive individuals on ART and healthy controls using OCTA. Secondary is to assess the foveal avascular zone changes among HIV positive individuals. And the last objective is to assess the microvascular changes in HIV positive subgroup. The individuals who are included in this study are between 18 to 60 years. They were having the better corrected visual activity of more than 20 to 25 or more, undetectable viral load, and they are on stable ART for at least 2 years, and the recent availability of CD4 counts within less than 3 months. And the people who are excluded from this study are having refractive power of spherical equivalent of more than plus or minus 6 diopters, OCTA, images of poor quality of OCTA images, and clinical signs of HIV-related retinal microvasculopathy or any concomitant systemic ocular pathology affecting the retinal microvasculation, or any history of intraocular surgery or trauma. Methods, it's a cross-sectional study where 50 HIV positive patients on ART results were compared with 50 healthy age and sex match controls. Octa performed with Heidelberg Spectralis machine, and through a software we measured the vessel density and vessel linear density, and FAZ area was measured manually in superficial and deep layers. So HIV group was subdivided into low CD4, which is less than 350 cells per millimeter cube group, and normal CD4 more than 350 cells. And this picture shows the Octa images. Picture A showing the nerve fiber layer, and picture B showing the superficial vascular plexus, C showing the intermediate capillary plexus, D showing the deep capillary plexus, E is choriocapillaris, F is choroid. The results, superficial vascular plexus vessel density is significantly lower in HIV group, and choroidal vessel linear density is significantly higher in HIV group. And there was a non-significant finding of foveal avascular zone area larger in HIV group. And we had also weak correlation trends with CD4 count. These results were not statistically significant. These are load CD4 subgroup, HIV subgroup had lower SVP VD and higher choroidal VID. And in this picture, we can see the VD comparison, vessel density comparison. Average macular vessel density is plotted in y-axis, and in the x-axis, the other parameters. If you see, the p-value is less than 0.01, which is significant for superficial vessel plexus, vascular plexus. And this one shows the VLD comparison in choroid region. Here also, the p-value is significant for HIV positive cases compared to controls. And FAZ comparison, though it is not significant, in this picture we can see the superficial vascular plexus had more FAZ when measured manually. And discussion, reduced SVP VD suggests early vascular changes, increased choroidal VLD in spite of reducing trends were shown as per the previous studies. Trends align with previous studies showing FAZ enlargement and VD reaction. Opta can serve as a non-invasive biomarker for systemic vascular health in HIV patients. And I would like to wrap up with a point that HIV positive individuals show retinal and choroidal microvascular changes even after starting on ART. Lower SPP VD and higher choroidal VLD, especially seen in lower CD4 counts. Opta is a useful tool for early detection of vascular dysfunction, and this may aid in the monitoring of systemic vascular risk in HIV. But we need further studies for we need further longitudinal studies compared with systemic biomarkers.
Good. So just wanted to know, like these HIV positive patients, how long they were positive, and were they controlled on ART?
Sir, they were controlled on ART. Minimum was 2 years, sir. We had taken 2 years, sir.
Minimum 2 years.
2 years they were on ART, sir.
They were on ART.
Yes, sir.
And diagnosed since 2 years.
Since 2 years, sir. Minimum was 2 years, sir.
Okay. And maximum?
Sir, maximum we had up to 5-6 years only, sir.
Okay,
Not beyond that, sir. Because once the changes appear in the patient, they were not eligible as per the study, sir. That was the exclusion criteria.
Okay. So if you see some retinal hemorrhages or
Yes, sir.
soft,
They were excluded, sir.
those patients were excluded.
Yes, sir.
So there was no vascular anomaly as such in these patients?
Yes, sir. Yes, sir. That was the exclusion criteria, sir.
Were they still on ART? Or
Yes, sir. They were on ART, sir. 50 patients.
ART has been
And you have studied FAZ, superficial and deep both?
Only superficial layer showed the significant enlargement of area, sir.
But
Deep-
that is not vascular density. You've not studied vascular
no, sir.
density.
No, sir. That was measured manually, sir. FAZ.
Measured manually.
Yes, sir.
See, I think since I was in college some 30 years ago, I remember we used to, when FFA was there, I think we were always told that never comment on FA without a color photograph. So similarly, I don't think that Octa has any, because it is the machine with the maximum amount of artifacts. And
Yes, sir.
sectioning is a big problem with Octa, because sectioning is something that needs to be done manually, and it is correlated again to the clinical pathology of the patient,
Yes,
and
sir.
also the color photograph or whatever, the systemic, the visual acuity that you have.
sir.
So I think with a very manual scanning and a manual measurement, I think
Sir, we use the software, sir, to process the images and to calculate the
no, the Z
binarized.
image. What software?
Sir, that is measuring the vascular density software.
No,
sir.
so that is what I'm saying. The vascular density can only be measured on a Cirrus 6000. It cannot be measured in any other of the octas as of now, at least.
Yeah.
Others are again. So that is what I asked you first. That have you measured the density, because you've not done the superficial density. No, you've just manually measured the octa. I mean,
Yes,
the
sir. We processed those images in a software, sir, and we calculated the vessel density, sir, by a formula, sir.
Right.
Sir, this is Heidelberg Spectralis German-made machine, sir.
Thank you.
Right.
So we will go to the next presentation. Arishi Narwal, is she here?
This is a keynote address.
Yeah. Keynote address on comparison of subfoveal choroidal thickness in pre-eclamptic, healthy pregnant and non-pregnant women.
And these two people are not there, no?
Thank you. Good morning, esteemed faculty and audience. My keynote address is on the study, Comparison of Choroidal Thickness in Preeclamptic, Healthy Pregnant and Non-Pregnant Females by Optical Coherence Tomography. So preeclampsia. Preeclampsia is a multifactorial multisystemic disorder occurring in approximately 5 to 10% of pregnant women worldwide. It causes various organ dysfunctions, including the visual system. And high vascularity with poor autoregulatory mechanism makes choroid particularly sensitive to the hemodynamic alterations in preeclampsia. Thus, assessing the choroidal thickness may be used as a predictive marker in preeclampsia. A very few prospective comparative studies are available on the choroidal thickness, and it is also limited by various conflicting results and small sample size. So the purpose of my study was to measure and compare choroidal thickness in preeclamptic, healthy pregnant, and age-matched healthy non-pregnant women, and to evaluate any correlation between the subfoveal thickness and the mean arterial pressure. So we took 30 healthy pregnant women, 30 preeclampsia women, and 30 age-matched healthy non-pregnant female as controls, so total of 90 subjects. It was a hospital-based comparative cross-sectional study, and the study duration was 12 months. The inclusion criteria was 20 to 40 years of age and with less than 4 childbirths, and best corrected vision of more than 6/9, and OCT images with good signal strength. We excluded any pre-existing systemic illness or pregnancy-related complications. After detailed workup, we included the best corrected visual acuity, IOP, the corneal thickness, spherical equivalent, examined the axial length, slit lamp, and fundus evaluation. Then we measured the choroidal thickness of both eyes in the SD-OCT in the EDI mode, and we also measured the mean arterial pressure. In the lab investigations, we did take urinary protein. So this is the representative image of the 3 groups, which is the subfoveal and nasal and temporal measurements are taken manually. And the A image shows the preeclamptic group, the B is the healthy pregnant group, and the C is the non-pregnant women. So our results, first we compared the obstetric, ocular, and systemic parameters of each group. Then we compared the choroidal thickness between the groups, and we found that there was a significant difference in the subfoveal, the nasal, temporal, and average choroidal thickness of both the right and the left eyes. So what do we see here? That the healthy pregnant group had the highest choroidal thickness, followed by healthy non-pregnant women. And the preeclampsia group had the thinnest choroid. The difference in the choroidal thickness in the 3 groups was statistically significant for nasal, temporal, and subfoveal average, both eyes except nasal CT in the right eye. And the correlation of mean arterial pressure was also done with this choroidal thickness, and it was found to be inversely related in all the groups combined. But it did not show any significance if compared with the single group separately. So the current study showed significantly less choroidal thickness in preeclamptic patients as compared to the other groups, and no significant correlation was found between the mean arterial pressure and choroidal thickness in preeclamptic patients. So this has a very strong implication that choroidal thinning in preeclampsia is not governed by multifactorial choroidal vasospasm and endothelial dysfunction, which is causing this thinning, and it is not solely attributed to the mean arterial pressure. We have other studies in literature, and there was no study, PubMed index study from India, so our study was the first one. Other studies had contrasting results as well, where few studies showed that there was a choroidal thickening, such as Kim et al. And Sharudin et al., and few studies showed that there was choroidal thinning in preeclampsia. This varied results could be because the various degrees of preeclampsias, and we made sure that all the 30 preeclamptic women in our study were of mild to moderate preeclampsia levels according to their urinary protein, and the severe preeclampsia was excluded for the comparable results. So in conclusion, choroidal thickness can be used as a biomarker in preeclamptic patients, as an adjunct to other parameters, and future prospective comparative studies with follow-up, larger sample size are required for better understanding. Thank you.
Thank you.
Thank you, sir.
In fact, like how can we use it clinically for this? Because eclampsia and preeclampsia would mean fluid retention.
Yes, sir.
Yeah.
So
But that would mean the choroidal thickness should be more?
Yes, sir. In healthy pregnant women, the choroidal thickness is increasing. But in preeclampsia women or the women which are going to go into eclampsia or severe disease, so as a part of an antenatal workup, it is a non-invasive thing.
That's so.
So we can screen the women who are at higher risk of developing vision loss. So we can, and also this adds to the literature that choroid is basically an eye to our systemic system. Any systemic disease can be correlated with the choroid, and the limitation of my study was also that we did not have OCTA, so choroidal vascular index and all these parameters are also yet to be studied in such systemic diseases. So choroidal changes are very important, which are occurring.
So what will be the pathogenesis in eclampsia, preeclampsia? Why it is thinning?
Yes, sir.
Is it because of hypertensive or some
It is-
atherosclerotic
Yes,
or
sir.
arteriosclerotic changes occurring there?
Previously, this was believed that because of it is a direct correlation with BP, choroidal vasospasm, and thinning. But newer studies and even our study adds to this literature that it is not only the arterial pressure, it is endothelial dysfunction, endothelial choroidal vasospasm, because of which this thinning is occurring. Otherwise, in healthy pregnant women, there is increase in blood flow, and overall the whole body has increased blood flow and also the choroid.
Did you correlate this to the refractive error and the
Sir,
axial length?
Yes, sir. So all the groups had comparable axial length, and we did a spherical equivalent also. So we had excluded any refractive error, which was +3 to -3. So all three groups were having comparable results statistically. Thank you.
Thanks a lot. Thank you.
Thank you, sir.
I think if those two presenters are missing, then we'll just close the session. Thank you. Thanks. We'll have a group photograph if those presenters are here. Yeah. We'll have a group photograph. ये है आपका sheet. Extra वाले तो इनको रहने दो. एक्स्ट्रा है वो 2000
इसमें रिजल्ट है